Hey everyone, we're back with another specimen today. This is number 85 in our collection, and the heart would have sat roughly in the chest like this. Anterior surface here, superior head here, inferior and legs down here, left, right, and then the posterior surface, the inferior surface of the heart towards the turntable. So we'll start off as we routinely do by trying to identify, at least externally, what appears to be the morphologic right atrial appendage. Here we have a triangular shaped, pyramidal shaped, or broad-based appendage consistent, at least externally, to be a right atrial appendage. So we'll go ahead and open this atrium here. We do find pectinate muscles that spill outside the confines of this appendage, consistent with the morphologic right atrium. We can quickly identify the oval fossa here and see that there is a defect in the oval fossa. So there is an intra-atrial communication in the true atrial septum here. And we can see immediately that there's also another atrial level shunt, another intra-atrial communication here, which appears to be consistent with an atrioventricular septal defect, as we do see a common atrioventricular junction with a common atrioventricular valve as well. So here we quickly find, once again, an intra-atrial communication in the oval fossa, as well as an AVSD type defect as well. We also find the coronary sinus, and sorry about that. Here is the coronary sinus. Here is the tendon of Totaro. And here is the right-sided atrioventricular valve. And so one would expect that the triangle of Koch would be bounded by the coronary sinus, the tendon of Totaro, and the right-sided atrioventricular valve. At its apex of this triangle would be where we would expect the atrioventricular valve to sit. Unfortunately, or the atrioventricular node to sit, sorry. Unfortunately, that would be roughly here. So if we extended out this tendon of Totaro, saw where the right-sided atrioventricular valve is, we would expect the atrioventricular node to sit somewhere here. Obviously not possible, because the atrioventricular node cannot be suspended in midair, and thus we would expect that in this heart, the atrioventricular node would be displaced from its usual position and be found closer to the coronary sinus right here. Okay? And that is why there is displacement of the atrioventricular valve in the setting of an atrioventricular septal defect. So now when we look, we clearly see the atrial level shunt that is part of the atrioventricular septal defect. We do find a common atrioventricular valve in this common atrioventricular junction. Here we find the inferior bridging leaflet coursing through this atrioventricular septal defect. And here we find a very dysplastic superior bridging leaflet with very rolled and scalloped edges. That may be a little difficult to appreciate, but I think it's hopefully very visible. What's also interesting is it appears that this is all largely one component, the left-sided component of the superior bridging leaflet that courses through the atrioventricular septal defect into the right ventricle. And the connections of this left-sided component of the superior bridging leaflet are directly into the ventricular cavity here, and not actually to the ventricular septum, consistent with a Rastelli C. So once again, really largely a large left-sided component of the superior bridging leaflet, which then has connections directly to the RV cavity, not to the ventricular septum, the crest or the septum itself, making this consistent with a Rastelli C. And once again, the superior bridging leaflet, highly scalloped, rolled edges, thickened edges as well. If we take a look at this ventricle, we can find that there is a septomarginal trabeculation here, consistent with a morphologic right ventricle. This RV cavity in this heart does seem a little smaller and hypoplastic. And as we look at this RV outflow tract, we can see the ventricular level shunt as well in this atrioventricular septal defect. So this is an atrioventricular septal defect with a large left-sided component of the superior bridging leaflet, making this consistent with a Rastelli C. And this heart has both an atrial and ventricular level shunt associated with it. If we look at the right ventricular outflow tract here, here's a septum marginal trabeculation. We find a semilunar valve that has 3 leaflets, as well as 3 sinuses, 1, 2, and 3 over here. There are no coronary arteries arising from within the sinuses here. So this is consistent with a morphologic pulmonary valve. And this would have been the pulmonary trunk, which has been transected here, which would give rise to the right and left branch pulmonary arteries. Just to point out, for completeness sake, the pulmonary valve, as usual, is in its entirety supported by muscle. If we flip the heart over, go to the posterior aspect of the heart, here is the left atrial appendage externally. We'll go ahead and open the heart up from its posterior aspect. Here is the orifice to the left atrial appendage. We can see that all of the pectinate muscles are confined within the appendage itself and don't spill out, consistent with the morphologic left atrium. We can see that the vestibule of the atrium itself is smooth-walled as a result of that. And once again, we can now see the intraatrial communication within the oval fossa. And here are the horns of the oval fossa here. And then now from the left side, we can appreciate the atrial component of the atrioventricular septal defect. In fact, we can really see the bounds of the entire atrioventricular septal defect here. We can see the superior bridging leaflet almost in its entirety, and this is the left component, which is quite large, and then has connections into the right ventricular cavity over here, once again consistent with what most people would refer to as a Rastelli C. Here is the inferior bridging leaflet coursing through the atrioventricular septal defect, and then there is a left mural leaflet here that has been transected. Here is the crest of the ventricular septum as well. Here is a ventricular cavity with fine crisscross trabeculations consistent with the morphologic left ventricle. Since this heart has a common atrioventricular junction with a common atrioventricular valve, we can't use the atrioventricular valves to guide us with ventricular morphology, so we do have to use its other features. For the right ventricle, obviously, the septomarginal trabeculation, and then for the left ventricle, it's fine crisscross trabeculations. Now we go into the left ventricular outflow tract here. Here's the crest of the ventricular septum. You can see that there's a scooped out appearance. You can see the ventricular component now with a ventricular level shunt of the atrioventricular septal defect. So once again, this AVSD has both an atrial and ventricular level shunt. The scooped out appearance consistent with an AVSD. And now you can also clearly see how the inlet component of this left ventricle is significantly smaller than the outlet component of the atrioventricular septal defect, with this discrepancy in the inlet and outlet lengths of the left ventricle being one of the other characteristics of an atrioventricular septal defect, as the aorta is no longer wedged between 2 atrioventricular valves, but is sprung forward or unwedged because there is a common atrioventricular valve, so it doesn't have 2 valves to be wedged between. We find a semilunar valve here now again with 3 leaflets and 3 sinuses. There are coronary arteries arising from 2 of these sinuses, and here's one of the coronary ostia here. We do see that so this is all consistent with the morphologic aortic valve. Here we see the superior bridging leaflet from the left, and we see that there is mitral aortic fibrous continuity, as we often see in hearts as well. So this is an interesting heart with an atrioventricular septal defect with both an atrial and ventricular level shunt, with a large left-sided component of the superior bridging leaflet that then connects directly to papillary muscles of the right ventricle, has no connections to the crest of the ventricular septum or the ventricular septum itself, consistent with what most people would refer to as a Rastelli C.